Good morning to one and all. This is a recording of the FFUS ISU USI collaborative workshop on urodynamics, and this particular topic is on pediatric urodynamics, which will be delivered on 15th of June at the Sri Ramchandra Hospital. So let me start with some basics. The terminology, it used to be different earlier, and then the ICCS definitions came. So what is enuresis? What is incontinence? What is nocturia? What is overactive bladder? What is bowel bladder dysfunction? I mean, these are some of the terminologies you may have to differentiate. So the enuresis in the past conventionally used to refer to inappropriate non-voluntary discharge of urine beyond the age of usual control, which is considered to be developmental age of 5 to 7 years. For example, if a little boy of 2 years passes urine on you, and then you won't say that that is a medical problem, but you would just laugh at it and then, change your dress. So that is a physiological process of attaining the bladder control, and that's what it used to refer to. So incontinence actually refers to involuntary loss of urine, also known as leak, beyond the expected age of control. And that is the current terminology for any incontinence is a leak or a constant soiling of the pad. It used to be conventionally referred to pathological inability to control. So like as urgent continence, stress incontinence, overflow incontinence, different types. So the ICCS definitions in 2016 defined a leak or incontinence into continuous incontinence or intermittent incontinence. Intermittent incontinence is referred to daytime incontinence or enuresis. So that is a nocturnal enuresis is actually enuresis. So daytime, anything in daytime is incontinence. There's no daytime enuresis. So we won't go down the pathway of enuresis or bedwetting because they are totally different pathologies and etiologies. Now, our topic is urodynamic assessment, and before any urodynamic assessment, it is important that we make sure that the child or the parents record the bladder diary. So the bladder diary must include the time of voiding, the volume of urine voided, if there is a leakage in between, when was the leakage, the amount of fluid intake, and how the stools was the nature of the stool. And it should be recorded over a period of minimum like 4 to 5 days so that we will have some idea of what's going on. For example, a child who is 9-year-old, the expected bladder capacity is the current formula is age plus 1 times 30 is 300 ml. On the other hand, the urine output depends on the body weight. So that's around 720 ml for 24 hours if it is 1 ml per kilo per hour. So in a child, probably the early morning void is like 120 ml. And as the day progresses, 6 to 7 voids are there of 100 ml each to making up to 720 ml. So up to 7 times, this is the normal voiding. Now, if the voiding is like, it doesn't have to be exactly like what it is. It can be variable between 150, 180, and then evenings can be 50-50. When the child is at home, probably it is more. Whereas when the child is at school, there is only 2 intervals. So during those times, the child holds. So even though the expected bladder capacity is 300 ml, when it is like a 50% or whatever capacity, the child has the urge to go. Now, if this becomes like multiple frequent voids like this, like 50 ml, 40 ml, or very small volumes frequent voiding, then we automatically know that there is a increased frequency. Now, a frequency is defined as more than 8 times per day, and a decreased frequency is less than 3. Nocturia is waking up the night to void. Nocturnal polyuria is a different entity where there is a larger volume, more than 130% of expected bladder capacity in the night time. And nocturnal polyuria is like more than 20% of the output happens at the night. Now let us come back to the urodynamic assessments. So the urodynamic assessments can be a simplest way is a home monitoring of the bladder volume and post-void residuals. This is very popular in the Western world, where they give the parent an ultrasound machine to measure the bladder volumes pre and post-void. And this is typically done even in newborns and infants who have undergone urological procedures. Then non-invasive voiding phase studies like uroflowmetry, those are the initial studies to assess um, the voiding phase, then ambulatory urodynamics, then invasive urodynamics, which you have all heard several talks on this, filling phase and cystometry. Then comes the video urodynamics. Then provocative urodynamic, this is probably in somebody with a bladder neck incontinence where you can occlude the bladder neck with a Foley's catheter and then do a provocative urodynamics, then biofeedback. So we'll try to see some of these over a period of time. Uroflowmetry is non-invasive, simple, but it's possible only in an older cooperative child. So this you should know. In a less than 4-year-old child, they may not void on command. So asking for a uroflowmetry may be like not always useful. Whenever I do a urodynamics, I always ask the people who are doing urodynamics to do a uroflowmetry, natural uroflowmetry before, because after a urodynamic in a child, the urethra is traumatized and then there will be a lot of lower urinary tract dysfunctions. And at that point, if you try to get a voiding phase, it's impossible. So it's always better to do a uroflowmetry before you start a urodynamics. And the curve and flow rate and uroflow nomogram. So also all these things are useful. This is a typical normal Uroflow curve, which can be multiple types of bell-shaped curves. And you have to be aware of what is a normal Uroflow. Uroflow and post-void residual is a simple tool to exclude obstructive uropathy. Typically, it occurs in meatal stenosis after a circumcision, like in a patient with a BXO, or it can happen after hypospadias repair, or it can be urethral stricture or post-urethral valve fulguration strictures. So all those things, by looking at the Uroflow and the PVR, you can easily tell what it is, like whether it is a well-shaped curve or an irregular curve or the staccato voided, or a lazy bladder, which is a plateau curve, and a prolonged flat curve. So all those things you can usually look at, and then you can also say whether there's something is obstructed curve. So combining Uroflow with EMG is a particularly useful step. And we have published that, Uroflow EMG is particularly useful in children with the lower urinary tract dysfunction. So there are 3 types of Uroflow abnormalities we detected in these children with the lower urinary tract dysfunction. So the first type is a dysfunctional voiding where there is a prolonged staccato trace with the active pelvic floor and a normal voided volume. Then idiopathic detrusor overactivity where there's a shortened trace, quiet pelvic floor and reduced voided volume. And detrusor underutilization disorder where there is a prolonged flat trace, quiet pelvic floor, and then there is a lag phase. So prolonged lag phase. These are the types of uroflowmetry. This is the normal uroflow, the first one. This is a staccato voiding with a lot of activity during the voiding phase. And then you have this high overactive bladder tower-shaped curve. And then this is the prolonged curve of a deferred voiding. So in a child with a lower urinary tract infection after detailed history, bladder diary, urine culture, and ultrasound, if you go for Uroflow EMG, most of the time you'll be able to get your diagnosis. So only when you have a hydroureteronephrosis or bladder wall thickening, we actually ask for urodynamics. Otherwise, it's avoiding dysfunction. So we go for Uroflow EMG. And if it is a dysfunctional voider, then biofeedback and treatment of constipation is what is needed. If it is an overactive bladder, then anticholinergics or even sacral neuromodulation can be useful. And if it is detrusor underutilization disorder, then timed voiding, CAC, all those things can be tried. Now, to quantify what is overactive bladder, I mean, we currently go by the high tower-shaped curve. But this curve itself can be because of multiple reasons. It doesn't have to be just because of an overactive bladder. It can be because of a deferred voiding. If a child is holding a 500 ml of urine, then you can still have a tower-shaped curve. But in an overactive bladder, the child cannot hold, so the volume is usually low. So to define that, we introduced this overactive bladder concept, the index, a new concept where we use the Uroflow index. A Uroflow index is basically a QAV by Qmax, and then time to Qmax, that is the time taken for the initiation, and then to the Qmax, and then volume voided as a percentage of the expected bladder capacity. So with that, we can tell whether somebody is a normal uroflow index. If it is less than more than 15 overflow OAB index, then probably it's a normal. Then if it is equivocal, then probably we have to look at whether there is a part of bladder deferred voiding is there, whether the child is holding too long, or whether there are some other factors. But even a typical overactive bladder, you do get the tower-shaped curve. The child cannot hold, and the volume voided is usually smaller than what is expected, and the overactive bladder index is less than 12. So this is an objective way of finding. Now coming to invasive urodynamics, it causes a considerable distress to the child, and there's a risk of sepsis. So typically we reserve the invasive urodynamic to a child with the neurological cause, like typically a myelomeningocele, spina bifida, tethered cord, or incontinence after a pelvic surgery. So that is the typical child where we go do all this. And we can also do it in conditions like post-urethral valve, where there is a valve bladder, and then intractable bladder dysfunctions, severe upper tract changes. So all those things can be an indication for invasive urodynamics. When it is typically not required, child with the bedwetting, a classical voiding dysfunction where Uroflow EMG alone is enough, or in a child with the VUR with no gallbladder dysfunction. We don't do urodynamics in all VUR patients, but if there is an evidence of bladder wall irregularity, or there is suspicion of bladder dysfunction, only we do it. So informed consent should always be there. The parent should get an explanatory leaflet. Urine culture should be negative. The bowel should be well prepared. You always get a natural flow uroflow before a urodynamic. One or more cycles of urodynamics may be required in a child, because the child may not be able to hold, and then they give you the command. The first desire itself may be an emptying. So antibiotic cover is a must, and child-friendly environment is a must. So the technical differences between a child and an adult. In a child who is less than 5-year-old or somebody who is wheelchair bound, you have to do it in a lying position. Whereas in an adult or in an older patient, you can do it in a sitting position, which is a conventional urodynamic position. The leak has to be monitored in a lying position, whereas in a sitting child, you can put the Uroflow meter below, and then the leak can be recorded. Now, the capacity of the fill rate is very low in a small child, unlike an adult, and they can't tell the sensation, and they can't tell the desire, like, when to void. They cannot void at will, so you cannot give a command to void, they simply void. So you just have to be there. So the most important thing in a pediatric urodynamics is the person who is going to give the report should ideally be in the urodynamic chamber during the procedure. And uroflow is typically not possible because of the small caliber of the urethra. So once you remove that uroflow, you get once you remove the urodynamic catheter, you only can get a uroflow, but not a voiding phase of a urodynamic study. So crying and distress can be some of the factors. So you have to be absolutely sure that the subtraction is very good before you start, and the rectal line is very important. So urodynamic in children has got certain important things to be aware of. One of them is bladder capacity. The bladder capacity used to be calculated by age plus 2 times 30, but nowadays the conventional ICCS definition says age plus 1 times 30. And in a child who is less than 1 year old, it is basically depending upon the weight. If the child is 10 kilos, then probably 75 ml. So that is the bladder capacity. So the fill rate is usually 10% of the expected capacity. So in a 3-year-old, if the bladder capacity is 150 ml, then you get a fill rate of 15 ml per minute. So it's not a standard fill rate like in adults. So slower fill rate may be even required in thickened bladders. So because a rapid fill may cause VUR, and then may cause a lot of unmask a lot of problems. So in a supine position, the calibration has to be done accordingly, and the rectal line is important. The rectum must be empty. EMG electrodes, I always prefer to have them because it gives you an idea of what is going on with the sphincters. The standard abdomen lines can be large in a pediatric urethra, can cause a lot of distress. So we have to go for the smallest size of abdomen line, and The custom-made lines can be used in older. For example, the 2 feeding tube method can be used in older children. So instead of this rectal catheter, you can actually make a custom-made catheter in an older child. So these are all possible in older child, but in a little baby, you have to use a smallest size lines possible. So getting the child quiet can be a challenge, but nowadays with the advent of cell phones, it's pretty much easy to make them watch a movie and then keep them quiet. I do not prefer them to be anesthetized or sedated because it is better to have an awake child and then you still can try to distract the child with various gadgets, and it is very much possible. The child cannot be hanging to the toilet for life, so you have to give the child a supporting stool, and there should be a backrest also. So that is when they can be relaxed, and there is an armrest also. That is how your urodynamic setup has to be. Now, starting the UDS, we have all heard about all these, the basics of urodynamics. Setting 0 is important. Calibration of transducers is important. Establishing reference level to the cubic symphysis and making sure that there is no air bubble in any of the transducers. These are all very important. I'm not going to go back into the details of this. We do sometimes do urodynamics via Mitrofanov. Only advantage is we can get a warding phase very easily in this kind of patients. So this is a patient who had a pre-augment urodynamic, which is a lot of unstable contractions and poor compliance, and after augmentation, the bladder has become much controlled. So the idea of urodynamics in a neuropathy is basically to identify the type of problem. It can be a bladder problem or a sphincter problem. The bladder can be overactive or underactive. The sphincter can be overactive or an underactive. So based on the combinations, if we have an overcompetent bladder and the sphincter, then you have a situation like the hissing pressure cooker. There's a lot of high pressure there. So there's a high risk of renal damage and a vesicular reflux. Whereas if we have only the sphincter, which is incompetent, and the bladder is flaccid, so you have a leaking bucket. So they have a retention, leakage, UTIs, but the kidneys are relatively okay. Now, you have an undercompetent sphincter and an overactive bladder. So this is like an open pressure cooker. So the bladder is okay because the sphincter is leaking. This is the usual scenario. But when you do the sphincter surgery, then you can actually make the problem worse. So you may have to do an augmentation and a sphincter surgery in these kind of situations. And again, if both are like undercompetent and under flaccid, then you have a leaking bucket. So these are all multiple analogies of a combination. So typically the Christmas tree appearance is what is happening in a neurogenic bladder. Urodynamics in posterior urethral valve, we can actually start urodynamic study as early as age 5, but in the Western world, they start much earlier to have a baseline. So the baseline urodynamics is only to see the progression, because the valve bladder goes through multiple stages. Initially, it is an overactive bladder where there is a role for anticholinergics or a beta agonist. And then they go for a small capacity and non-compliant bladder where you have to carefully decide whether an augment is needed or a nighttime catheterization is needed. And then in the myogenic failure stage, which happens during adolescence, and this is when they end up in needing a transplant also. So at this stage, you may have to decide whether a CAC is needed, whether via natural or Mitrofanov in addition to the nighttime catheter. So as I said already, urodynamics in VUR is not routinely recommended in all children. A select group of children with the dysfunctional voiding symptoms alone are the ones who warrant urodynamics in a VUR. Uroflow itself may find a dysfunctional voider, and MCU can reveal an abnormal bladder, and in select patients, you can do a filling phase study. So a typical normal urodynamic study is where the pressures are stable throughout, and there is no increase in the rise in pressures of the pediatric. So in a compliance is basically a derived value. So compliance is delta V by delta P, and it has got an inverse relation to the slope. The steeper the slope, the lower the compliance. So the normal compliance is like 30. So in a patient with a mild impaired compliance, it's like 29 to 20. Then moderate is 19 to 10. Severe impaired compliance or non-compliant is less than 10. So when you have less than 10, it goes up rapidly. So it's a rapid mountain-like thing. Whereas, in impaired compliance, it's a slow rise. And even less milder in poor compliance is a very, very slow rise. Bladder instability, also known as hyperreflexia or neurogenic detrusor overactivity. These are all contraction waves which happen during the filling phase. Typically, they are associated with the leak. So each leak will lead to reduce in pressure. And if the leak doesn't happen, then you have a combination of hyperreflexia and instability. So if there is no leak, the pressure keeps on climbing up, and then it also becomes a poorly compliant bladder, which is very damaging to the sphincter. So here you can see the EMG has been placed and the sphincter is contracting with each rise, preventing the leak. So this is a very dangerous scenario here. An ideal urodynamic report should have details of filling phase, the bladder function, what is the detrusor activity, whether it is a normal, overactive or underactive, then bladder sensation, whether it is normal or increased or reduced, then what is the bladder capacity, whether it is a low capacity bladder, and whether the compliance is poor. So that we should mention all these things in the report, and also about the leak, whether the sphincter is continent or not. Then we can also add various points like leak point pressure, DLPP, LPP, all those things. Then voiding phase, we can actually look at the detrusor activity, whether it is an underactive or acontractile or areflexic. These atonic bladders and all typically one looks for in an adult, whereas in a child it is pretty difficult. But in an adolescent patient with the posterior urethral valve and valve bladder, we can detect a atonic bladder. And the sphincter detrusor sphincter dysenergia, you need a voiding phase. So indications for video urodynamics, typically in a patient with a large bladder diverticulum, the pressures may be high, but basically the pressures will be vented by the diverticulum. It also happens in those with gross VUR, where the entire reflux is the entire pressure is taken up by the refluxing system. So here, when you report, you have to mention that the pressures appear normal, but it cannot be commented because there is a gross VUR. So we cannot actually say. Also, if the patient is leaking out, for example, this is a patient with a sacral agenesis and the bladder neck is wide open. So the patient is leaking out throughout, and there is also a reflux. So the urodynamics will look normal, but you have to report in the comment that this is a situation where and ideally urodynamics, video urodynamic has to be done, because we cannot comment on this because the patient is either having a reflux or patient is leaking through. So when in the absence of video urodynamics, I prefer to get at least a voiding cystourethrogram beforehand so that I know what is the condition. So natural fill cystometry or ambulatory urodynamic, I'm not going to go into it, but you can connect these kind of devices to a notebook computer, and then you can connect via 5 French suprapubic catheter inserted 24 hours earlier for monitoring the intravesical pressure. And this is more of a thing in an adult rather than a child. But biofeedback is something which is frequently used in children. It's pretty expensive to be used in our continent, but it's widely available abroad. So the main objective is to unlearn the bad habits of straining and contracting the pelvic muscles and maintain the relaxed pelvic floor during voiding. So it can be an EMG biofeedback where they put a electrode and then teach the child how to relax the external sphincter. So when the child relaxes the external sphincter, the fish opens and then catches the smaller fishes like a jellyfish or something. So they try to relax the sphincter by watching this, and then they learn. Then Uroflow biofeedback is another method used for dysfunctional voidings, where they are taught how to see the Uroflow and then alter the Uroflow accordingly. So that is in short about urodynamics, and I'm not showing the videos because you will be seeing the live demonstrations at the end. So if you have any questions, I'm happy to answer. Thank you.